Where did we leave off? Dr. Kimmy, anything else that you wanted to get out there at the end that I didn't ask you or that you didn't have time for?
I think we didn't expand much on the insurance barrier to effective primary care, which is a real problem.
And that's something we heard about in the Public Insight Network. So I'm sorry, go ahead.
And there's a big change that's coming right now. So
Wait, hang on. Do you have a mic?
yeah, there you go.
That's fine.
There's a big change coming in the market. So as these exchanges are being set up, most of the exchanges are going to have as their primary plan benefits in which a patient is insured 100% for their preventive medicine. Then they have a $3,000 to $5,000 deductible. And then they're insured for catastrophic healthcare needs above that. And what we're finding is a lot of healthcare or a lot of regular companies in St. Louis this year have already gone to that format with their employees. Is that what happens is people when they get sick they'll go to the emergency room, they'll have maybe a $1,200 or an $1,800, $2,000 bill, and given the economy the last 4 or 5 years, the average family household doesn't have $2,000 sitting around to do that, and so people are having trouble paying these. And so we're going to get into a situation, I worry, that they'll come in for their physicals maybe, or we'll be able to convince them to get their mammograms because those are covered. But when they have diabetes, they need to see us multiple times a year to keep that in tight control. They have other conditions that really does need care. It's going to be hard to get people in the door because they're going to see all of that expense up front directly out of their pocket. That may be a problem.
Is this like a whole new donut hole we're talking about here?
A little bit, yeah. It's bigger than a donut, though.
and not delicious. I'm sorry. Okay, I felt like someone wanted to jump in.
Well, it's on a slightly different topic, but I wanted to correct a misconception, which is that I absolutely love my job.
Right.
I've been a primary care doctor for 10 years in St. Louis, and I have seen some of my patients are incredibly ill. I see them every month or every 3 months, so I've seen some of my patients 50 times. And I know them extremely well, and I have equally as good relationships with my nurse, my medical assistant. I have this incredible support team. I am so happy at work. It is exhausting, and I am breathless, and it is an adrenaline rush all day long. But being able to work within a community health center where I have a number of resources available to me under one roof is really enjoyable.
So do we need more people like that talking to your classmates?
We do. We need more people like that talking to my classmates. I think almost no one in my class went into primary care this past year, which was really a shame. There are a lot of reasons for that. Some policy reasons that we didn't really talk about in the show. The residency, which is actually paid for by federal government. So when you go and do a residency, the federal government pays your salary, actually allocates a certain number of slots for things like primary care and family practice specialties. And they have the power to maybe adjust those, and that's something that's been discussed. I think there needs to be a lot more outreach into care. Another cool thing that we were talking about kind of between segments is the idea of a National Health Service Corps. This is another service that was actually just recently expanded under the ACA that will basically pay for you to go to medical school in exchange for you serving time as, that sounded bad, not serving time in that sense, but you going into something like family practice. So you go in and work in an area that is an underserved region for a time or time and a half. So if you went to medical school for 4 years, maybe for 6 years in those regions, and I think many of those physicians stay in those regions.
DROTC.
Working with the community. Exactly.
Okay.
I'm a National Health Service Corps member myself, actually, and that's how I got to be with People's Health Centers, as they were a designated site. And a lot of people stay on, once they've completed their commitment, shall we say, to the National Health Service Corps. But
just like a lot of Teach for America folks become career teachers.
Yeah.
You might not otherwise.
I have a
Yeah, go ahead.
question for Heidi. Why, it's great to love the job that you're doing, but why do you think that more of your colleagues who went to medical school with you didn't go the route that you did and went into specialty care and so on?
Just in case the mic wasn't picking up there, he was asking, why did not more of your classmates take the path that you have?
Probably money, probably a sense of busyness. I know that a lot of professionals prefer to be an expert in one thing instead of having to feel like they need to be an expert on every single part of the body and any particular issue that a patient may bring to them. It's a number of reasons.
I think that's fascinating because, I really agree with you there. The complexity and the scope and the depth and the breadth of your practice is not, it really is easier to become reductionistic and focus on an organ as the window to the soul. And it's not that way. But I still think that one of the challenges here when it comes to barriers is the scope of practice issue. And we didn't really have a lot of time to speak to that.
What do you
today.
mean? What does that mean?
Well, it means that physicians, because of malpractice and other concerns, they're in a position, and time constraints, they don't get to use the knowledge, skills, and abilities that they really possess. The same is true in this state, as was mentioned, with nurse practitioners. We train to national standards. We prepare people with a skill set, and then they go to other states to practice because we're so repressive in this state. And so I really think many health providers get international experiences even to go where they can really feel whole about what it is they're doing and contributing. So we've got to look at the barriers of malpractice, the legal aspects, the even human resource regulations just constrain us so much. We're such a regulated field that we don't get the freedom to do what we know we can do.
Can we take that to back to the nurse practitioner? I'm going to play Mike Czar. I'm going to hand one one to James. We had and we're sorry,
I'm
Maria.
mic'd.
Oh, you are Mike. Okay, James, is it? Yeah. Here, let me give you this one. So we've talked about you like you're not here all night. So what's on your mind?
Well, we're here, first of all. I think that physicians in particular need to reassess. We are, in a sense, in a crisis mode in this country, and we will be more so when the 36 million or however many million new people come on board with the Affordable Care Act. Anyone who's worked in an emergency room knows when something's going on, you look around and you say, who can do what here? Let's get this done. And we need to approach healthcare in that sense right now. We need to look around and say, who can do what? And if there's a nurse practitioner that can do something, if there's a medical assistant that can do something, we need to maximize their scope of practice. We need to maximize the skill set and the intelligence and the academic training that they have. Not minimize it, not restrict it. There are territorial issues, as one of the other panelists discussed tonight, and for many different reasons. Physicians don't want, and many physicians and physician groups don't want nurse practitioners encroaching on their bailiwicks and on their territory, and that's understandable. But in the spirit, I think, of healthcare, in the spirit of healing people, we need to really start to appreciate what can we do and how can we do it better and how can we do this in an equitable and fair way.
And I think it's important to point out too that no nurse practitioner is trying to say that they're a physician or that they're going to take the place of a physician. And there is some big misconception there. And I think that the focus really is on what we can do to enhance the system, what gap we can bridge that's there.
How do we get more nurse practitioners? I believe I've read that there are a waiting list to get into school for
Faculty. So, yeah, I think.
Sorry.
Well, there are issues around faculty. The reality is there are waiting lists. There are people that start in their undergraduate level building their clinical experience and building their knowledge base. So by the time they get a master's degree, and some of them are working at I notice, a doctorate of nursing practice, these are very skilled people. They have a particular focus that they bring to the healthcare team. And again, a lot of it's around health promotion, health maintenance, living with disease. Again, so we get into debates around the supervision. Can a physician supervise every part? Well, no, because physicians aren't trained in all of those areas any more than nurses are trying to train and act as physicians. We're really trying to function as nurses. And that seems to be lost in the politics somehow, legislative politic. Because individually, as we look around this table, we know everyone's collaborative and everyone enjoys wonderful relationships that are respectful.
Not me at all.
Well,
that's why I will not let Ed sit at the post-show table.
I've got just one comment since I'm the lawyer in
Yes, please.
practice, so I have to say something. The Missouri legislature has recognized that nurse practitioners do represent a very important part in what physicians do.
Oh, here, hold your mic a little closer there, sorry. So the legislature, go ahead, I'm
Yeah,
sorry.
the legislature has recognized that nurse practitioners play a very important role, I think both in terms of preventive care, in terms of the access point. Missouri law has changed to allow nurse practitioners to essentially be, I guess, more remote from the supervising physician starting at the end of August this year. A very significant change, actually.
It's significant until you come. I just came from Oregon for 5 years, where for 20 years nurse practitioners have been impaneled as independent practitioners. I'm sorry, this is repressive. The fact that this was the only state, when I stood in the Institute of Medicine at the National Press Club, and had to talk about nurse practitioners in Kansas City on the state line, they walk across the street, they're not allowed to function. That is not progressive. That is a repressive set so I laud the change, but I cannot in any way support that this is in any way enlightened. And a good number of people here practice outside of what the repressive laws state and function more like they do in other states. But we are losing critical primary care providers to states that around us, and we're ranked 37th or 39th in health problems in terms of disparities. This is absurd. So this is not progressive. That's my point.
Heidi, the recruitment you brought up from your office, and that was kind of new to a lot of folks. Tell us, expand on that if you would.
Well, in 10 years, my nurse practitioners in my office have needed to interrupt me in the middle of a patient visit to have me sign a narcotic prescription. They can't sign home health nurse orders without me signing it for them, and they can't make referrals without me signing for them. That's not making the system more efficient. And in 10 years, I have never once seen a prescription, a home health order, or a referral that I disagreed with and gave it back to the nurse practitioner and said, reconsider. 100% of those were appropriate, and I signed. And it's not a very good use of time or resources.
For anyone.
Perfect example, again, of constrained human resource. We have, and you have stated it beautifully, and I think we can't approve death either. We can't sign death certificates. I mean, it's absurd, the kinds of things that we require physicians to do. That doesn't.
We're almost out of internet streaming, and so go ahead. I just saw you reach for the mic, so I want you to get on your mic what's on your mind.
I would only say that working to the top of the license is really
Yes.
and regardless of how a state looks at it, it's looking at this under the law and under regulation. And in Missouri, physicians are the apex, and when something abnormal happens or goes wrong, it will ultimately revert back to the physician under the written collaborative practice agreement. So it's a matter of education. It's a matter of assuring the public that it's safe for providers other than physicians to care for them. It's a team approach. I'm a strong advocate of advanced practice nurses. I've worked with tens of them. The point here is educating the public, doing what's safe, and making sure that we're providing the care that patients come to expect in a civil society. That's what this is about, in my view.
Okay.